I hope all the candidates are here. We'll start bang on 1:30, and I think all of you know I'm Dr. Nag and Dr. Bhargava.
Radharamanan. Dr. Radharamanan.
Rahman. The rules are you get 4 minutes for your presentations, and there will be 1 or 2 minutes for questions and answer. Okay, so we'll start. There's slight change of the schedule, or just the the way we call it, because these two presenters has got some other commitment elsewhere. So first we'll call Mr. Dr. Joy Gopal Agarwal.
Today is 16th.
यही तो है यहाँ पर, ये दूसरा है ना। यही तो है।
Number is A05995.
Should I continue? Okay. Yes. Good afternoon to everybody. My presentation is it is absolutely necessary to advise toric IOL in case of moderate regular astigmatism of less than 1.5 diopter during phaco. There is no financial interest. The purpose is in case of moderate regular astigmatism of less than 0.1 diopter during the phaco, based on the incision management of astigmatism using the coupling effect, we can deliver very satisfying result to the patient. These are my inclusion criteria. These are the exclusion criteria. Now, the clinical examination includes the normal eye checkup, including the biometry and the IOL power calculation by the IOL master, 700 corneal topography, qualify the nature of astigmatism, and a steep meridian assessment. Better to take the reading in the dioptric power in plus notation. It is important in the incisional management of astigmatism during coupling effect. All these examinations were repeated post-operatively at 3rd, 15th, and 30th day, and after 2 months, if possible, after 6 months. These are the surgical techniques for clear corneal incision. Axis is marked by the bent needle in the patient sitting upright in the at the slit lamp. Based on the coupling effect, the phaco procedure is completed by using 2.8 millimeter clear corneal incision at the marked steep incision. And the end, the original phaco incision is extended in the keratomes, depending upon the size of astigmatism. For opposite clear corneal incision, another stab incision at the same axis, 180-degree apart, at opposite end, given at the same time. For the toric IOL, it is the usual procedure as calculated by the toric calculator. This study is the retrospective comparative one. That is, here the surgeries are conducted during 2022-2023 at my clinic. The patients are given appropriate counseling regarding the advantage of the toric IOL if astigmatism is more than 0.7 diopter. Even if the patient does not want toric IOL during the economic reason and other reason, we opt for clear corneal incision and or either clear corneal along with the opposite clear corneal, aiming at the least post-operative astigmatism. The total number of cases is 309, and this is the schematic diagram. Total number of cases, out of which the 236 cases are given either clear corneal incision or clear corneal incision along with the opposite clear corneal incision. And 73 cases are given the toric IOL. Out of the 236 cases, 152 is given the clear corneal incision when the astigmatism point is less than 0.7 diopter, and 84 cases are given clear corneal incision along with the opposite when the astigmatism is more than 0.7 diopter. result is very satisfactory. And here that in first group, we have satisfactory result. It is 85.5 percentage. In the second group, it is more around 67 percentage, and for toric cases, it is 71. Here the distribution refractive astigmatism pre and post-operatively. It shows that it gives the very good results in all the three cases, three methods of treatment. Here again shows that the post-refractive astigmatism result is very good if we apply a clear corneal incision or clear corneal with opposite clear corneal incision. The results are their standard deviation is very low. Here again the t-test shows all three operative techniques are considered relevant as satisfactory. All the three patients have p value is less than 0.05. So clear coordination along with the opposite techniques is a robust correlation with the compared with the toric IOL. This signals the toric IOL is not necessary in cases of astigmatism less than 1.5 diopter. To conclude, all three procedures has success rate are quite comparable and all statistically significant, that is less than 0.05 and paired test. And besides clear coordination required no additional expertise, instrument and time. So under limited resources, toric IOL is absolutely not necessary in cases of moderate regular astigmatism, and easy effort to optimize the astigmatism management. It is a very good idea for the mass treatment if you follow the simple rule of coupling effect.
Thank you,
Thank you.
doctor. What is your follow-up period?
It is around 6 months.
6 months.
If patient comes, at
Yeah,
least
there is
30 days is minimum, but we can follow if the patient comes. Generally, patient comes within 6 months after 6 months.
No, the problem with the incisional recovery is as the time goes on.
Yes,
Yeah.
that is the problem.
Yeah,
But
that is
even
what
then, we get the very satisfactory result. Even if the patient we don't go for the toric IOL, it gives a very satisfactory. I am doing regularly in all cases.
I just want to know why your toric results are only 70% showing success. Normally, most of the standard methods in which we do the toric, the result is close to 90%.
No,
So
yes.
even with less than 1 point. So is there an issue with the marking issue or the placement issue? What was the error in 30% in your
Yes,
toric group?
Yes, it is 70%, but in that slide, I have also shown that in some cases it is very good. In some cases there is slight deviation, either due to rotation or either there is marking. Even though it is
the second one?
good for the majority of cases.
Anything you want to ask?
So that's fine. Thank you.
Thank you. We call upon Dr. Jitendra Jethani now for this paper on comparison of defocus incorporated multiple segments versus highly aspheric lens set on myopic progression.
Yeah. Should I start?
Yeah.
Good afternoon, respected judges. We all know that myopia prevalence has been increasing dramatically, and in the recent decades, including in India. Now it is estimated that by 2050, in India also, we will have around 48% of the patients will be myopic. So what are the key factors which are responsible for this growth? Most common now has been documented as peripheral hyperopic defocus. There is a defocus of these rays which are coming posterior to the retina, and this defocus is creating the growth, axial growth of the eyeball. With this background, two new spectacles, MyoSmart by Hoya and Stillest by Essilor, have reported variable success in controlling myopia progression. With this background, we did a study to compare defocus incorporated multiple segment, that is DIMS, versus highly aspheric lenslets, that is HALT, on myopia progression. Now, our financial disclosures. The children were selected if they were prescribed either Hall or DIMS lenses, were younger than 12 years, and were without any other ocular abnormality like strabismus, amblyopia, or any other ocular or systemic anomalies. All the children were non-responders to atropine, and they had already stopped atropine 3 months prior to being given glasses to account for any rebound effect that has taken place. The standardized 1-year spherical equivalent refraction and axial length changes from baseline were included. Cycloplegic autorefraction, dynamic retinoscopy, axial length was measured with NIDAC AL scan biometer, and the average was calculated. So the primary outcome for this particular study was spherical equivalent refraction, which was calculated by adding the spherical with a half of cylindrical power, and the secondary outcome measure was obviously the increase in axial myopia, that is axial length from the baseline. The minimum follow-up period was 1 year, and the outcomes were compared for the measurement from baseline to 1 year. The baseline was once the atropine was stopped and we had waited for 3 months. Only the results of right eye were compared to avoid any confounding bias. We are not going. So a total of 38 children were included in the analysis, 16 in the Hall group and 22 in the DIMS group. The mean age was comparable. In DIMS group it was 9.6 years, and in Hall group it was 8.6 years. Pre-intervention, we can see that there is a spherical equivalent progression of 0.76 in DIMS group and 0.86 in Hall group. And pre-intervention axial length progression is also given, and post-intervention after 1 year. So this is per year progression, which I am showing. The differences in outcome between the two groups were analyzed with unpaired t-test. Results were two-sided. P-value of less than 0.05 was considered significant. To curb the myopia progression, these are the two new glasses which have been launched around 2-3 years back. DIMS was launched 2 years back. Hall was launched 1.5 years back. Now there have been some morphological changes between the glasses. The DIMS has around plus 3.95 diopters of peripheral refraction, whereas Hall lenses have a variable peripheral refraction. And this has been shown that Hall lenses do fare better than DIMS when there is a head-to-head this thing. So we compared this in Indian eyes. This is the first study to compare the two aspheric lenses or two peripheral defocus lenses in Indian eyes. We all know that the neurons are more densely packed in the central retina, but the peripheral retina total accumulated number of neurons are far more, and therefore technically if you have a larger area of functional zone, that should work better. So Hall lenses have a larger defocus area than the DIMS lenses, and they did show a better myopia control, but the control was not significant. So statistically it was not significant. So we conclude that both the lens designs are equally good. Hall lenses were slightly more effective, that is clinically, not statistically. And although both lenses are effective and they can be used to reduce or slow down the progression of myopia, more long-term studies are needed to actually prove the efficacy of lens and also to see whether there is any rebound once we stop using these glasses. So thank you so much for the interest. Thank you.
Thank you. Thank you, Doctor.
I have a question,
Yeah.
Jitendra.
Yes, ma'am.
What is the cost of both of these lenses?
Both the lenses are almost same cost, so that to the doctor it is 8,700 rupees and MRP is 15,000 rupees. So that was one of the major reasons why we had given it in patients who were progressing beyond atropine. So all the patients were atropine non-responders. They were not first-line therapy.
But how long did you wait to decide that they were non-responders?
We waited for almost 8 months, madam.
Okay. And there was absolutely no...
No,
The
there was
myopia
absolutely,
was
yes.
progressing.
So basically what we did was we gave them atropine. Principally what we do is we give them atropine, and after 6 months we reassess and increase the dose of atropine.
Okay.
And we increased the dose of atropine, they still did not respond. So after that we waited for 8 months, and then we waited for 3 months as a washout period. So if there is any rebound of atropine, that should also go away.
Okay. Thank you.
So
Yes, sir.
basically, your the mean age group was 8 to 9 years old.
Yes, sir.
You tried atropine for say nearly 7 months, waited, so another 1 or 2 years gone. So your then from that is your base point, and you are
No. We started when they were 6 years of age. This was the age when they were given glasses. This was the mean age when they were started on glasses.
right. But the atropine, it's a non-responder to atropine, so they were increasing quite a lot significantly.
Yes, yes. They
before
were
that?
increasing
How
more
much?
than 0.5 diopter per year. That is the standard
0.5 diopter
definition.
per year.
That-
So if they by that time another 1 or 2 years gone, so by that time usually the progression will be less anyway, isn't it? So say
Sir, that holds
year
good
from
for-
say, if it is recruited at 9 years age and you are starting the treatment say around 12, 10, 11, then usually the progression that time is already reduced.
Sir, that is true for atropine also, no? If we are treating them on atropine, their progression should reduce over a period of 1 year with age.
No, but that doesn't always happen, doctor. It doesn't always happen.
Yeah, no, it doesn't happen.
See, because whatever may be written and whatever the studies may show, but each patient's body is unique.
Unique.
And they respond differently. Because I have seen myopia progressing even at the age of 40.
Yes, yes.
When we say kids should stop progressing by 18, 20, 21 max, myopia should stop progressing. It doesn't work. The body follows its own rhythm.
Its own rhythm.
Thank you.
Thank you so much.
Yes.
Thank you. Thank you.
Now, who do we call upon?
Our next one
First,
is normotensive value of AC versus A ratio, and it's presented by Dr. John Kennedy.
Are you the chief author? Sorry? No, okay. You're just presenting.
So please just
Start.
tell us your name, please. Then.
Shiny, sir. It's my
Shiny.
second name. They have
Okay.
written.
All right. Thank you.
Sanidhi.
Shiny, shiny.
Shiny is not
Normal
here.
value of
My second name is there. Shiny JK. They have written John Kennedy as well.
okay.
But you're Sanidhi. Okay. Yes.
That's my name, but they have written.
Okay. So do we write present because the main speaker is not present now? Go ahead, please. Start.
Good morning. I'll be talking about normative value of accommodative convergence accommodation in Indian population measured by heterophilia method. So near response is a complex neuromuscular process which the main aim is to maintain binocular fixation and clear retinal images despite change in fixation. It composes of accommodation, convergence and meiosis. So synkinesis of these movements are necessary to maintain a good binocular single vision, thereby stereopsis. So AC by A, that is accommodative convergence per diopter of accommodation, is a vital parameter which determines coordination between these movements. AC by A ratio helps in determining the ocular motility disorder and to manage cases with abnormal AC by A ratio. So AC by A ratio is determined by following methods, gradient and heterophoria method. Gradient method, which is more of a theoretical method, which measures the amount of convergence generated by diopter of accommodative effort. Heterophoria method, which is more of a clinical method, which determines the presence of distant near disparity in prism diopters. Heterophoria method has convergence as a component and it measures intrapupillary distance. So it varies in various races and ethnicity. So it has more clinical relevance. So our study is a cross-sectional study. The aim is to determine accommodate AC by A ratio in Indian population by heterophoria method, which is measured in a normal asymptomatic adults. The place of study was in a tertiary hospital in Western Andhra Pradesh. We selected 100 eyes, the 100 eyes of patients who were attendants of patients visiting the hospital, healthy eyes with no refractive error or no eye pathology. And the age group selected was 19 to 50 years. They all underwent baseline ocular investigation in the form of refraction, a slit lamp evaluation, and cover-uncover test to test for both distance and near and fundus examination. The foria for distance and near, which was determined by prism bar, fixation target of 6 by 9 is fixed. And the IPD is measured by a horizontal ruler with the first Purkinje image as reference. And AC by A ratio is calculated using the formula. And IPD in centimeter, the N is the near deviation and D is distant deviation and D is the working distance in diopters. So our result showed mean intrapupillary distance of distance is 62.88 millimeter and the average FORIA measured for distance was 1.82 and near was 4.20 prism diopters, and AC by A ratio was 5.49 prism diopters. And the previous studies showed which was gradient method, which was generally done, and the gradient method, and this showed there is variation. The heterophoric method is relatively lesser, the values derived is relatively lesser, and previous studies which were conducted by heterophoric method, which were again differing than our study, because it was higher, because the race and the ethnicity difference was noted. Ours is Indian and the previous study was of Australia and UK. So to conclude, the normal range of AC by A ratio by heterophoria method in our study population was 4.41, which was correlating with the normal average AC by A ratio, which was 5.49. Thank you.
What is original about your study?
Ma'am, the last study which was conducted, which was by heterophoria method, which was in 1972, not in southern population. So we wanted to determine AC by A ratio by heterophoric method in southern population, which was not done. And there it is, because IPD and it has IPD and convergence as its component. So it varies for race and for different population. So that's why we wanted to.
Okay. For the benefit of the audience, can you just tell what is the difference between the heterophoria method and the gradient method of measuring AC by A ratio?
In heterophoria method, we measure with help of IPD. IPD is a component of, IPD is intrapupillary distance, which is a component of heterophoria method. So, for example, if you take Indian population, the eyes are smaller than the general Western population. So the convergence required will be lesser for Indian population compared to other population. But gradient method, which is a theoretical method, which doesn't have IPD measurement or convergence as its component.
What does it use? What does the gradient method use?
Gradient
Do
method.
you know about the grade? So if you are studying a comparison, see, there are two methods.
Yes, ma'am.
So you need to know the other method as well if you are using one. So do you know about the gradient method?
Gradient method has its formula,
So tell us.
which
Okay.
Okay, it's all right. You don't know. It's okay. Fine. Thank you.
thank you.
Yeah, no, I'll call Nas.
Next. Next.
Okay, next is Parul Satwani. Yes. Regression of mild myopia using extended blinking therapy.
Extended blinking therapy. What's that? Go ahead.
Good afternoon, everyone. My topic is the regression of mild myopia using extended blinking therapy. So, myopia, also known as nearsightedness, affects all the age groups starting from early childhood, and nearly 22% of the world's population is affected by myopia. Myopia, along with its progression, is a global pandemic today, as described by WHO, and by 2050, more than 50% of the world's population is going to get affected by its myopia and its vision-threatening consequences. Various methods like glasses, contact lenses, drugs, and exercises have been tried to halt the progression of myopia. So we conducted a prospective comparative study in a tertiary care hospital in eastern India. We included mild myopic patients with spherical equivalent of less than -3 diopters between the age group of 11 to 40 years, and we excluded all the patients with any known ocular or systemic diseases. These patients were divided into two groups, Group A and B, with 40 participants in each group, and Group A was given extended blinking exercises, Group B was given conventional treatment, that was glasses. After 6 weeks, visual acuity, spherical equivalent, and biometry was observed in both the groups, and results were analyzed. So, extended blinking exercises, we asked the patient to open the eyes and look at a distant object for 5 seconds, and then gently close the eyes for the next 5 seconds, and then again open the eyes for the next 5 seconds. And we asked the patient to repeat this cycle for 5 minutes in the morning and 5 minutes in the evening. and these were the results that we got. In group A, logmar visual acuity, the mean logmar visual acuity was found to be 0.280, that reduced to 0.070, and spherical equivalent was found to be minus 0.7, that reduced to minus 0.2 in the right eye. In left eye, same logmar visual acuity mean was 0.298, that reduced to 0.063, and spherical equivalent was minus 0.6, that reduced to minus 0.2. There were no changes in keratometry or axial length values, which was, and in group A it was found to be statistically significant. Group B, there were no significant changes noted. So here we have in group A an improved visual acuity and reduced spherical equivalent, and in group B no changes were seen. In our study, there were no changes in the biometric parameters following blinking therapy, that suggests that there may be some other factors contributing to the improved visual acuity, such as increased retinal function or sensitivity. Various methods may be attributing to this improved visual acuity observed after blinking exercises. One of these, as given in previous studies, is that after exercises, anterior chamber angle increases, that causes changes in iris configuration. This ultimately changes retinal thickness, causing structural remodeling that helps forming a clear image on retina. As the function of the retina improves, it leads to decreased refractive power and spherical equivalent. Another mechanism attributing to this improved visual acuity can be improvement in the near point of conversion. Along with this, it helps reducing eye fatigue and affect vergence-related binocular vision function improvement that causes reduction in the eye fatigue. With significantly positive findings in our pilot study, we aim to study further on a larger sample size, including various grades of refractive errors, and to investigate and analyze changes in the retinal parameters. From our study, we conclude that blinking exercise is a cost-effective strategy in halting the progression of myopia at an early stage, thereby helps regression of mild myopia and decreasing the burden of myopia in our population. Since the burden of myopia in young children is increasing day by day, we would like to find out ways to prevent its progression in cost-effective and simple ways. Thank you.
Thank you. I have a question for you. You mentioned that you divided your population, study population,
Yes,
into
ma'am.
two groups, 40-40.
Yes,
But
ma'am.
the second group, you didn't do anything specific to halt the progression of myopia. All you did was give them conventional glasses.
Conventional glasses, yes,
So
ma'am.
then where is the comparison? Because
Ma'am.
here you are actively doing something, you're doing blinking exercises
Yes, ma'am.
to halt the progression of myopia. But there, we all know that just giving glasses is not going to halt the
Yes,
progression
ma'am.
of myopia. You did not put them on low dose atropine or anything else, contact lenses
Yes,
for that
ma'am.
matter. So then does your study stand ground?
Yeah, that's the control actually.
Yeah, you need a
Con-
control.
Yeah.
That is the control.
That's the control.
Group B is the control.
It's a control, but then the control needs to be comparative, not just conventional glasses.
Yeah, just could you explain a bit more
About
how you use the term using extended blinking therapy? How do you do that? Extended blinking therapy. What exactly?
5 minutes.
Sir, extended blinking therapy is the form of exercises that we have given to the patients. In that, we'll ask the patient to look at a distant object for like 5 seconds, opening the eyes for 5 seconds, then closing the eyes for the next 5 seconds, and then again opening the eyes for the 5 seconds. Basically, we are promoting
how
the
long-
complete
how-
blinking
Five and five.
For 5 minutes?
Oh,
that
for
will-
5
Morning and
minutes in
evening.
the morning and 5 minutes in the evening, sir.
This
Twice.
is the same like some alternative
Cupping.
medicine people using palming.
Palming,
No,
palming, right. I was just
They
going to
uses
say
palming, and Second World War, actually First World War, Japanese soldiers, they used to put a sandbag on the eyes in the night time so that they can fight in the daytime because they get it. But but here there is no axial length difference.
Yes, sir. There were no biometric
but,
changes seen. We would like to further. We would like to study for how like these
but
changes.
you have
No.
explained it with so many theories.
Yes, sir.
but
There
what-
were many
what is-
articles that were suggesting that yogic exercise and
so this is a yogic exercise basically.
and blinking. Ma'am, we have modified it. Like yogic exercises will include the movement of the recti muscles and these like extra.
But here there is no yogic exercise.
No, no,
It's
ma'am.
only blinking. blinking.
Yes, ma'am.
Is this documented? Is this a documented?
Ma'am, we've seen
way?
that blinking helps in digital eye strain, and that causes a good improvement in the quality of vision. So we were trying to see whether it is helping to.
Who came up with this idea in your department? I would like to know.
And when you do the therapy, who actually takes with the stopwatch? Do you
Yeah.
do yourself or the patient?
Or do you leave it
just
to the
5
patient?
seconds.
Ma'am,
who looks after that
we
5
explained the patient as to.
And then left it to them.
Yes.
So then how did you control it? There was no control from your part. It was what the patient was doing at home. He may have done it, he may not have done
Okay.
it. How do you know?
Ma'am, actually, like next in my thesis also we have
No,
taken.
they're not talking about what you're going to do next. In this study, what you have done. So, there has been no clinical record on your part to see whether they have really done the exercises for that many minutes, morning and evening. It has been left to the discretion of the patient and the attendant to do it, isn't it?
Yes, ma'am.
Okay, thank you.
Thank you.
Thank you, ma'am.
So next we call Dr. Prasanjit Kalita. Dr. Prasanjit, no,
Yes.
President Nikota is Dr. Rima, sorry.
Rima ka chal raha hai.
कौन सा है?
Rima ka
Third?
chal raha hai.
अच्छा अच्छा.
Now we are going according to our
Okay, okay, okay. Rima Kachal. Why did you take the first two out of? Because they had.
they have other commitment, they have to go.
Please start.
Good afternoon, everyone. Today I am going to speak on a study on digital eye strain among patients attending a tertiary care hospital. As we know, globally, newer advancement and technological innovations has changed the world into new and various dimensions. Since the invention of computer, information are passed digitally from communication to living assets to healthcare to education system. Like industrial revolution, digital revolution has put the entire globe in one screen, but still it has its own advantages and disadvantages. As outlined by the American Optometric Society, digital eye strain encompasses a cluster of ocular and vision-related problems attributed to prolonged uses of desktops, laptops, mobile phones, tablets, e-readers, and storage devices. My aims and objectives were to assess the prevalence of digital eye strain, to assess the various risk factors of digital eye device usage pattern, and to correlate them statistically with clinical features. This is a hospital-based prospective study which is conducted in Assam during October 2022 to 23. 2,030 participants were screened for digital eye strain-related symptoms and history of digital device uses. My inclusion criteria: all patients who attended the OPD from 11 years to 70 years, high myopia, any eye inflammation, cataract, variety of glaucoma, eye surgery, any retinal pathology were my exclusion criteria. So, in the results, 43.5% belong to the age group 11 to 30 years, followed by 34% between 31 to 40 years. Female were 60% and males were 40%. 62.5% patients had education level of graduation or above. 52% had no optical aid. 38.5% had used spectacles. We have assessed the risk factors such as average time spent for digital device uses per day, approximate screen distance, contrasticity like light and dark, an ideal way of digital device uses. This is the distribution of various symptoms of digital eye strain in the study participants. The more common symptoms we found were headache 70%, watering 60%, and dry eye 50%. The role of gender was found to be statistically significant in all the symptoms except watering, and the role of race was also found statistically significant in case of dry eye, foreign body sensation, watering, headache, and eye rubbing. This is a table showing association between risk factors and clinical symptoms. 30% used digital device for less than 4 hours, 60% used it for 4 to 6 hours, and 15% used it for more than 6 hours. And 70% used approximate distance of screen less than 50 centimeter, while 30% used more than 50 centimeter screen distance. 41.5% patients took break after 30 minutes of continuous uses of digital device, while 58.5% didn't take any break. So in the results, dry eye, watering headache, temporary difficulty in gaze, and blurring of double vision were statistically significant with average time spent for digital device uses. Dry eye, foreign body sensation, headache, temporary difficulty in gaze, double vision were found to be statistically significant in contrast to approximate distance of digital device uses from eyes. In context to taking preferred break after 30 minutes of continuous uses of digital device, all were statistically significant except eye rubbing and double vision. We took more than 11 years of patients, as in today's era, all age group people are using digital devices. The 43.5% belong to 11 to 30 years of age group, 34% belong to 31 to 40 years of age group, and 22.5% belong to 40 years of age group. Similar studies were done by Thomas S. et al., where they found that 55.4% were males and 44.6% were females. Khan et al. And Santa Kumari also studied similar paper in which they mentioned headache as the most common symptom. So in conclusion, I want to say that headache, watering, and dry eye are the more common symptoms seen in case of digital eye strain, and all these were statistically significantly associated with average time spent for digital device uses, approximate distance of digital device from eyes, and taking preferred break after 30 minutes of continuous uses of digital device. There's no source of funding, no conflict of interest. These are my references. Thank you so much.
Thank you. Any questions?
Just one question before you go. Yeah. The result, the incidents are more higher in younger age.
Yes, sir.
But one of the symptoms, dry eye, watering, these are more common, usually not actually told by the younger generation, but more for the older generation.
Yes.
But you said over 40, they have less symptoms. Okay. First thing, don't you think that over 40 they don't use mobiles or laptops nowadays?
Yes,
Over
yes.
40, lots of people nowadays do more, and they get more dry eye symptoms because with ages the dry eye
Yes,
make
ma'am.
more obvious, or they get more symptoms. So why there is a skew, or why there is a the results are why different?
Maybe because nowadays in younger generation they also use lots of technological devices.
Has any single patient has told you at the age group of 15 or 20, they're doing all the time in mobile, has they actually ever mentioned that I suffer from dry eye, I suffer from sort of pain, ache, headache? Has they mentioned? I don't think. It's probably interpreted, or you just sort of gave leading questions. Otherwise, they never say, because they know their parents are there, and if you say that it's the symptoms due to that, they won't be allowed. So I don't think they ever say that oh, you have got any symptoms. Either they don't have or they don't bother.
Yes, sir.
So I think it is not, probably the result is not reflecting the true story.
Yes, sir.
Okay, thank you.
Thank you.
Thank you. The next person to come is Dr. Radhika Kasilanka. Is she presenting? Okay. She's going to talk on efficiency of Barrett Universal 2 and SRKT formulae using immersion ultrasound versus optical biometry. Go ahead.
Good afternoon, everyone. Today my paper topic is a study of Barrett's 2 versus SRKT formula to calculate IOL power using immersion ultrasound versus optical biometry. Financial interest is nil. Introduction: cataract surgery has now evolved to the status of refractive procedure. So estimating the IOL power accurately is crucial for cataract surgery refractive outcome. One of the commonly used formula, the Sanders, Ritzelf and Kraft theoretical formula that was introduced in 1990, is formulated as a combination of both regression and theoretical approach and has been found to be accurate, particularly in eyes with axial length more than 27 mm. The Barrett's Universal 2 formula, an updated version of Barrett's Universal formula, was introduced in 2010 by Graham D. Barrett and has shown promising results so far. Aim is to compare the predictive accuracy of refractive outcomes after cataract surgery using SRKT and BUT formula by using immersion ultrasound and optical biometry. Objective is to evaluate the influence of biometric method on the accuracy of each formula. My materials and methods: the study type is cross-sectional analytic study with 60 patients, 30 patients in each group, and duration of study is 9 months, done in a tertiary hospital. Informed consent is taken, institutional ethical clearance was taken. Inclusion criteria is patient above the age of 50 years and existence of age-related immature cataract and no history of previous surgery of anterior or posterior segment of eye. Exclusion criteria is with any retinal or corneal pathology, traumatic cataract, congenital cataract, complicated cataract, glaucoma, squint, and corneal degenerations, and corneal high astigmatism. Methodology is patient demographic details have been recorded, and patients are divided into two groups, Group S and Group B. In Group S, again divided into two groups, 15 in each group, that is immersion group and biometric group. And in same division is done in Group B. All patients underwent a comprehensive ophthalmic examination, including best corrected visual acuity, tonometry, slit lamp examination, fundoscopy. Biometry was done using immersion method and optical biometer, and ARK machine was used. All patients underwent standard phacoemulsification procedure with 2-mm incision, and implantation of foldable IOL is done and performed by a single surgeon. Only uneventful surgeries were included, and best corrected visual acuity was measured at post-operatively 6 weeks. Refractive error predicted was obtained was tabulated. Comparisons of outcomes in both groups was performed. Statistical analysis, the collected data was entered and analyzed using Microsoft Excel 2019. Independent sample t-test was used to compare the means between two groups, and paired t-test was used to compare the means within the group, and p-value less than 0.05 will be considered to be significant. In results, there is no significant difference in predicted error in both the groups, and there is a significant difference in the obtained error in both the groups and within the groups. In a discussion, in Dimiana et al., with 34 patients, the study concluded that Barrett's universal 2 formula outperforms both the SRKT and Haig's formula for highly myopic eyes, whereas in Kutumalol et al., with 244 patients, Barrett's universal 2 formula performed the most accurate formula in the prediction of post-operative refraction over a wide range of axial lengths. My limitations of study are, as we included only uncomplicated cataract surgeries, no prediction can be made for eyes with unusual K or skewed anterior to posterior segment ratio. And our study was performed on cases in which only foldable IOLs were used, and different lens models should be investigated in the future studies. And the conclusion is the Barrett universal 2 formula provides better predictability of IOL power calculation than SRKT formula, and this is also more accurate when it is calculated using optical biometry. Thank you. These are my references.
Thank you.
Well, you have mentioned the conclusion, but your results don't match your conclusion. Your results says it's equal, and then you are saying that Barrett is superior to SRKT. How does this conclusion match your study results? You agree that no? You only mentioned that it's equal. There was no.
There is significant difference in obtained error, sir, but there is no significant difference in the predicted error.
Okay.
In predicted error, there is no significant difference, but in obtained error, there is a significant difference.
So why is Barrett called a universal formula? Any idea?
This is a new generation formula and automated.
No, it is called universal because it works across different axial lengths. So in your sample, it should have the whole range of axial lengths for you to have a meaningful comparison between the two. SRKT works well in the normal axial length eyes. So definitely that is what is shown. The error of the axial length calculation is out because you're doing immersion calculation. The only error that can happen is your formulation error. So formulation error is only possible if you have the whole range of errors. So that is the reason why you got that result all right.
This is tested by the single person, or readings were taken by the single person, or
Single person.
single person?
Single
Okay.
optometrist.
Thank you. Now the next person to give their presentation is Dr. Dipti Singh. Is she there? Okay. She's going to tell us about atoll sign in posterior lenticonus. Sorry? Your
Dr.
Kajal Pal.
Huh.
It's okay, that's all right. The presenting author is Dr. Kajal Pal. I'm sorry about that.
Good afternoon, respected judges. My presentation topic is atoll sign in posterior lenticonus. Introduction. Posterior lenticonus is a rare progressive disease characterized by protrusion of posterior lens capsule along with the lens cortex into the vitreous cavity. It may be associated with local thinning or absence of the posterior lens capsule. So chief complaints of the patient presented to us was a 22-year-old male with complaints of diminution of vision in both eyes. Left eye was more than right eye since childhood, but it was worsened more since last 6 months. Visual acuity in right eye was finger counted 2 meters, which improved with to 5/60 with pinhole, and in left eye it was 2/60 with no improvement with pinhole. On retinoscopy, scissoring reflex was observed in his right eye. Intraocular pressure in right and left eye was within normal limits. This is a slit lamp showing posterior lenticonus and intact posterior capsule in the right eye, and the other figure is showing the left eye showing advanced cataractous changes with a collapsed posterior cone. This is ultrasound biomicroscopy of the right eye, which is showing posterior cone with subcapsular cataractous changes, and the left eye showing advanced cataractous changes with a collapsed cone. So these are the examination findings. The adnexa conjunctiva were within normal limits of the both eyes. Both eye corneas were clear. Pupil of both eyes were normal in shape and normal in reaction. Lens of the right eye showed posterior lenticonus with cataractous changes, and left eye showed posterior lenticonus with advanced cataractous changes with collapsed cone. Fundus was normal in both eyes. Management. Patient was operated on right eye with phacoemulsification and 3-piece IOL placement in the bag with uneventful outcome. And left eye was operated 1 month later with single-piece foldable IOL placed in sulcus. Outcome. So best corrected visual acuity in right eye was 6/6 and in left eye was 6/24, which was most probably due to amblyopia. Discussion. The lens is surrounded by a lens capsules, which is a basal membrane secreted by the capsular epithelial cells and is mainly composed of type 4 collagen. Lenticone is localized bulging of the lens capsule, which can reach the diameter of 2 to 7 mm. On a slit lamp, it is characterized by transparent, localized, sharply demarcated conical projection of lens capsule and cortex, usually in axial section. In early stages, retroillumination shows an all-drop configuration. Advanced stages, it is associated with subcapsular and cortical opacities. Pathogenesis of posterior lenticonus remains elusive, but various hypotheses are given, like rupture of posterior lens capsule, hyaloid artery retraction or trauma, congenital weakness of posterior capsule, or aberrant hyperplasia of the subcapsular epithelium, etc. In bilateral cases, genetically determined congenital weakness of the posterior lens capsule is likely, which is usually X-linked and autosomal dominant. The presentation may be varied from asymptomatic to complex astigmatism, leading to amblyopia and strabismus. All patients develop cataractous changes with time at the level of the lenticonus, which can spread to the adjacent subcapsular cortex. Posterior lenticonus is reported to be associated with other ocular and systemic congenital anomalies like Duane's retraction, retinal pigment epithelial lens colomas, anterior chamber angle anomalies, axial myopia, morning glory syndrome, whereas Alport down and Loeys syndrome are reported systemic associations. A new MPPC syndrome having bilateral microcornea, posterior megalolenticonus, persistent fetal vasculature and chorioretinal colomas have also been described. Diagnosis is mainly clinical but can be difficult in asymptomatic patients. In oil droplet sign and fishtail sign can be seen as described as seen here in the figure. We are proposing an atoll sign in advanced cases of posterior lenticonus with intact posterior capsule on slit lamp examination. Positive atoll sign has more favorable prognosis since posterior capsule is intact. Hence, posterior chamber intraocular lens implantation will be more feasible with better visual prognosis. Atolls are annular mid-ocean geographic formulations which are water body lagoons surrounded by rocks, sand and gravel. Similarly, advanced posterior lenticonus with intact posterior capsule, which appears like atoll, with the central posterior cone, which is clear, appears lagoon, is surrounded by the lens material showing cataractous changes. The term atoll is derived from a Maldivian, the way we choose word atoll. Thank you.
First of all, you have only one case. You've
Yes,
shown
ma'am.
only one case. Ideally, this should have gone as a poster instead of a free paper, but that's not your fault. So, it's fine. It's an interesting case that you have chosen, and the sign that you have showed is also good. So,
Just tell me what exactly the atoll sign. Is it the slit lamp view? It is the ultrasound, the OCT, anti-segment OCT view, ultrasound view. You know the oil droplet, you can see also in the retinoscope.
Yes.
So what exactly the atoll sign?
Atoll sign can be seen on the slit lamp, sir. On the slit lamp, when you do slit lamp microscopy, then you can see the atoll sign. And advanced cases, you can see atoll sign. In the early stages, you can see oil droplet reflexes.
But whether you land up with complications or not, that doesn't depend on the atoll site itself. You need to know with the ultrasound or anterior segment OCT whether there is a dehiscence in the posterior capsule or not.
Yes.
So just seeing the atoll sign, it doesn't really mean much
So,
for you,
so
for your management?
so that was what our studies like. If it is there is a positive atoll sign, this means that the posterior capsule is intact. So we can place a
Have you
posterior
compared
chamber.
that whether you felt it is atoll sign and then did the anti-segment OCT to check the dehiscence of the posterior capsule?
So
Whether
we
that
did. So
it
we
is
did the
directly
ultrasound
linked?
biomicroscopy in which we could see that the posterior capsule was intact.
Okay. Okay. Thank you.
Thank
Next, we have Dr. Neda Ahmadi. Is here? Yes. Relation between extended screen time and axial length, a prospective study.
Should I start? Good afternoon. Myself, Dr. Neda Ahmadi, and I'll be presenting on the topic relation between extended screen time and axial length, a prospective study. There's no financial interest. The development of myopia is influenced by both genetic and environmental risk factors. The usual progression in myopes between 6 to 11 years is approximately 1 diopter per year with 0.03 mm per year axial length elongation, and between 12 to 16 years it is approximately half diopter per year with 0.17 mm yearly axial length elongation. The adoption of digital smart devices constitute a new form of near work wherein children spend prolonged, uninterrupted period of time with closer viewing distance than the conventional books. This has tremendously increased during COVID-19 pandemic. Thus, we aim to study the effect of digital screen devices on progression of myopia and evaluate the changes in the axial length with the myopic shift. It was a prospective observational study conducted between September 2020 to February 2022. All the school-going children with physiological myopia between the age group of 5 to 18 were included, and children with amblyopia, strabismus, pathological myopia, retinal and congenital disorders, etc. were excluded. A total of 196 children were taken up after satisfying the criteria. Data was collected through a structured questionnaire, and average daily time spent using devices were quantified by self-reported estimates. A comprehensive ophthalmic examination, including cycloplegic refraction and axial length measurement, was done, and patients were followed up after 6 months. Coming to the results and discussion, there was no significant difference in age and sex distribution, and the mean age was 11 years. The most common type of devices used were of handheld types as they were more convenient. The mean screen time was about 6 hours, which can be attributed to online education system and increased recreational activities during lockdown. Similarly, Mary et al. Showed that mobile exposure of more than 4 hours per day, and Hansen showed that more than 6 hours per day were significantly associated with progression. In our study, it was found that out of total 196 children, 172 had progression of myopia. Among these 172 with myopic shift, it was beyond physiological limit in 127, with maximum being axial type of myopia. The mean screen time was 6.45 hours. The mean change in spherical equivalent was minus 0.87 diopter, and the two showed a positive correlation with the R value of 0.58. Also, Foreman J et al. Showed that more the duration of screen time, more will be the myopic progression. The mean change in axial length was 0.25 mm. A positive correlation was found between change in axial length with the myopic shift with the R value of 0.94, which was consistent with the finding of Zhang X et al. So, I would like to conclude that excessive usage of digital smart devices during pandemic has accelerated the rate of progression of myopia, with axial elongation being the major component. Thus, digital screen time can be regarded as a modifiable risk factor, which can prevent the anticipated myopic epidemic by the year 2050. Moreover, axial length measurements can be used to predict the onset of myopia, monitor the progression, determine the risk of associated pathologies, and evaluate the effectiveness of myopia management. Hence, regular screening must be done at every 6 to 12 months, not only with cycloplegic refraction, but also with axial length measurements. It is recommended to limit the screen time to 2 hours per day and follow some preventive measures like use of laptops over handheld devices, following 20-20-20 rule, and encouraging outdoor time of at least 2 hours per day. Lastly, and most important, is to create public awareness regarding the effect of indoor near activities and reduced outdoor time on incidence and progression of myopia. Thank you.
Thank you. Is it 2 hours per day a lot of screen time every day? I mean, generally,
Yes,
I don't think we recommend that. On weekends, we would allow them maybe an hour and a half of screen time. But every day, I feel half an hour should be more than enough.
Ma'am, according to American Academy of Child and Pediatric Child and Adolescent Psychiatry, they have recommended the screen time according to the age. Like between 5 to 18 years, they have recommended like about maximum 2 hours per day. And below that, below 5 years, they have recommended up to 1 hour. Below 2 years, that is between 18 months to 24 months, they have recommended less than 1 hour. And below 18 months, they have recommended no screen time, absolutely no.
See, this is American Academy.
GG.
We are talking about Indian conditions.
Yes, ma'am.
So, in America, they don't have neighboring children to play with. Here we do. So, I think we need to find out the ideal amount of time for Indian standards. That's not part of your study, I agree. But I still feel 2 hours a day is a bit much.
Yes, ma'am. Ministry of Education has recommended some guidelines for educational screen time. Like they have recommended to reduce it to 30% of total educational time. The online education which is given, it should be less than 20 per day, and less than 20 minutes per day. Then in between the educational time, they have recommended to give 10 minutes of break after every 40 to 45 minutes, which is more feasible than following a 20-20-20 rule. And along with that, they have also recommended to limit the online video games by creating an age limit and also limiting the time. And then apart.
I just want to know, you said 2 hours.
Yes,
In
sir.
your data, did you actually have children who were actually seeing less than 2 hours and their myopia did not progress? Do you
No,
have
sir,
it in your data?
Sir, actually having a
Ah.
control group is very good for the study, but my study was conducted during COVID time. So at that time, finding a control with less screen time was
Yeah,
not possible,
that's
sir.
right.
Okay.
And your the age group was from 8 to
5 to
18,
18.
5 to 18.
Yes, sir.
How many of the age group, say beyond 15 or 14, they had the increase of myopia which was corroborated with increase of axial length? Because after some time it is not still known why myopia progresses, but the axial length remains same. So have you got the data that beyond 15 years old age children, how much it matched with their axial length progression? The myopia progression was matched with their axial length
Yes, sir.
progression?
The relation between axial length and the amount of myopia is not very linear and it is not very constant. But the matching, I mean, more linear is found in older children as compared to younger children, because in younger children, the axial length progresses more as compared to amount of myopia.
Okay, thank you.
Thank you, sir.
Next is
Professor Pankaj Chaudhary.
Professor Pankaj Chaudhary. Yes, sir, please come. And he's going to be telling us about the impingement of electronic gadgets overuse on myopia progression among young people. Please go ahead, sir.
It is more or less the same what previous speaker has told. So it was done again in the COVID period. So it is the electronic gadget overuse. I think all of us have used a lot in that period. So it was impossible to tell our kids not to use, because that was the only way they were doing. So myopia is becoming a major epidemiological problem and its prevalence is growing worldwide. By the year 2050, 49.8% of the world population is expected to be suffering from the myopia and 9.8 from high myopia. The long period of close work like reading, writing and mobile phone use all cited as the possible influences. So purpose was to determine the effect of mobile and laptop overuse on the progression of myopia in young people at 3 time of points at the 6 months of intervals. A prospective observational study was done from January 19 to September 20, done over the 400 eyes of the 200 myopes, categorized into the 3 groups based on the degree of myopia. A cycloplegic refraction and spherical equivalent was calculated in the time 1, 2 and 3. Progression was calculated as increase in the refraction between time 1 and 3. A task-specific diopter per hour was calculated based on the questionnaire survey. So that dioptric hour is calculated by number of the hours used and the distance and the type of the device used. So they were divided into low, moderate, high myopes, and depending on the number of the duration used, it is less than 2 hours, 2 to 4 hours, 5 to 6 hours and more than 6 hours, and progression was seen and odds ratio was calculated, and the p-value was calculated according to that. So in the mobile use, the number used less than 2 hours was taken as a reference, and the significant values were seen when it is more than 0.001. So association of progression when the distance of mobile used is also taken by taking a questionnaire that how they are using it, at how much distance they are using, because in the COVID period most of the time it is over the bed, and all of us are, not only the younger people, all of us are also using the mobile very close to our eyes. The association of progression of myopia with the task specific laptop diopters per hour was also calculated in a younger generation, those who were in preparing for NEET or doing their work from home. So the result shows mean age of patient with a low, moderate and high myopia was 18.62 plus minus 3.1 and 17.65 plus minus 3.5. Male to female ratio was 1.04. The task specific diopter per hour were 20 plus minus 10 with the progression as compared to no progression in 10 plus minus 10. So to conclude, the myopia progression risk was significantly higher in eyes with a longer task specific mobile and laptop diopter hours per day. Myopia onset on a younger age leads to the high myopia in adult life, and high myopia is associated with the increased risk of severe and irreversible loss of the vision. Thus, this study concludes that overuse of these electronic gadgets has a significant adverse impact on the myopia progression in the younger people. Educating and instructing the healthcare providers, children and their patients on reducing the screen time and taking a frequent break while using electronic gadgets will help to prevent the further myopic progression. Thank you. So its clinical implication is the same what we have already talked so many times, how to reduce it. We have not done axial length in this study, the reason being of the COVID protocol going on in that period, so not to be used that probe again and again. So it is only the spectacles and dioptric cover we have used.
That means you only used the progression in their
in the dioptric powers.
In the refractive powers.
Yes, only.
As they came to you.
Because most of the things were done in that period by the non-touch techniques.
Right, so I agree. Where are you from, sir?
So I am from Riva Medical College, Madhya Pradesh.
Okay. Thank you. That was a nice presentation. Next we have the presenting author is Dr. Naina, and it's about role of spectacles in management of migraine. Truth or myth, please. Only 2 more left. We finish in time. We have till 2:45.
Good afternoon, everyone. So my study is on role of spectacles in management of migraine, truth or myth. Introduction. Migraine is one of the most widespread debilitating condition with a global incidence of 14%. A significant number of migraine patients turns to ophthalmologists for consultation. Even though small refractive errors do not typically result in substantial headaches, serious refractive errors can result in headaches. So even in migraine, even these small refractive errors can act as a trigger. Coming to need of the study, migraine headaches negatively impacts the quality of life and overall productivity of a person. So preventing various triggers is the most effective management approach for migraine. So we aim to explore the role of spectacles in migraine management, including potential psychological impacts. Our objective is to determine the effect of spectacle correction on frequency and intensity of headaches in migraine patients. We included 250 clinically diagnosed migraine patients attending ophthalmic OPD at HIMSS Hassan. It was a non-randomized interventional study. We excluded all other types of headache, including cluster headache, tension headache, and secondary headaches. All high uncorrected refractive error, more than 1 diopter, spherical or cylindrical error were excluded, and patients already using spectacles were excluded. Patients presenting in acute phase preventing ocular examination and patient having pre-existing ocular diseases were excluded. So methodology, apart from detailed clinical history, we have taken detailed history of headache, and we have done grading of migraine at the beginning of examination, and we have given appropriate spectacle correction, and follow-up was done after 3 months, and grading of migraine was done. So the majority of our patients fell in age group of 21 to 30 with a 58% female population. And coming to grade of migraine, 48% was grade 1, 44% of patients had grade 2 migraine and 8% had grade 3 migraine. Refractive errors, majority of the patient, 32% had cylindrical error and 38% we found no refractive errors. Coming to follow-up, 69% of, after 3 months, 69% of patients showed improvement in the migraine grade. 27% continued with the same migraine grade and 4% had worsening of the migraine. So among patients who were prescribed with plano glasses, 72% patients showed improvement and 25% continued with the same grade and 2% showed worsening. So similar studies were there where they have correlated between migraine headaches and refractive errors. And in our study, out of 250 clinically diagnosed migraine patients without any significant refractive errors, when treated with spectacles, nearly 70% of the patient improved symptomatically. Even those without any refractive errors, using plano glasses, 72% showed improvement. So to conclude, even mild and non-significant refractive errors seems to be linked to migraine. Tackling the link between mild refractive errors and migraine holds the key to dial down both the frequency and intensity of these headaches. So clear lenses leads to clear mind. Plano glasses stepping into the spotlight as a psychological touch in migraine. Thank you.
Thank you. I think I like that point about the using plano glasses as a psychological measure to help migraine patients get better.
Yes.
And it seems to have worked in your study.
Yes, ma'am.
There was no mention of the lenses, whether there was any tint in the lens, whether there were any ARC coating, whether there is any photochromatic. Have you used any of those on the lens or just clear plano lens?
Plain glasses.
No tint, no
tint.
thinning. You have checked that there is no,
No,
when
sir.
you actually advised, did you check whether they had the ARC or their tint or their photochromatic
No, sir,
lenses
no,
used?
Not from photochromatic glasses.
Because
plain glasses.
that could be one of the cause.
Yeah, because it can prevent the one of the trigger is light. So
Light effect. See, because even if we do not prescribe photochromatic glasses, opticians tend to tell the patient कि ये अच्छा रहेगा आपके लिए, ये coating करा लीजिए, ये tint करा लीजिए, it cuts down the blue filter. I'm telling you, blue filter is such a big thing nowadays that even my children refuse to believe me when I tell them it is of no use. They tell me there are studies. Ma, you don't know. So I tell them, okay, I don't know, you go ahead. Because, see, these days everybody reads up on Google. They use the internet more than half the times before they come to the doctor. So you should have specified that, whether, as sir said, that whether it was without any tint and no photochromatic, all that. But it's a good attempt to understand migraine, which is really a problem for the patient to deal with. Thank you.
Thank you.
Next presenter is Dr. Deepak Tiwari. Is here. Dr. Deepak Tiwari? No? Okay. We'll come to the next presenter, that is Nandita Trivedi.
Tiwari is absent.
She will be presenting scleral contact lens in complex corneal situations in a tertiary eye care center.
Good afternoon, everyone. I'm Dr. Nandita Trivedi, and my presentation is on scleral contact lenses in complex corneal situations. Scleral contact lenses are wide diameter, rigid gas permeable systems that vault over the whole cornea. Based on the size, they can be divided into semi-scleral, mini-scleral, or large scleral contact lenses. Let's have a look at the quick fit guide. The first step is to select the lens size based on the limbal clearance. The next step is to look for the central clearance. This is based on the sagittal height. The next step is to look for the peripheral edge alignment, and the final step is to do over refraction for the patients. Now, the uses of scleral contact lenses, it can either be used to improve the visual outcome of the patients, or it can be used to improve the quality of life of the patients. Here is a case series in which we are discussing various case scenarios for which scleral contact lenses have been prescribed in our setup. This is a case of 24-year-old male who was diagnosed with an overlap of PMCD with keratoconus, and for this patient, the acceptance TILC was performed, that is, both eye tuck-in lamellar keratoplasty was performed. Post-operatively, acceptance was 618 in both the eyes, which improved to 69 in the right eye and 612 in the left eye with scleral contact lens trial. Discussing various case scenarios of keratoplasty, a 27-year-old male underwent right triple procedure in 2019 for central leukomatous corneal opacity. Post-operatively, the vision with acceptance was 660. The RGP was unstable and scleral contact lens was given and the vision improved to 66. Another case of a 40-year-old male who underwent TPK for left perforated corneal ulcer. Post-operatively, the vision was 4/60. With RGP, the vision improved to 618, and with scleral contact lens trial, the vision further improved to 66. A case of 14-year-old male who was diagnosed with both eye keratoconus, and in the right eye, DALC was performed. In the right eye, the vision post-operatively was 618. There was lens drop was noted with RGP, and on scleral contact lens trial, the vision improved to 69. Discussing a few rare cases, a 32-year-old male, he underwent LASIK 10 years back, and he had been complaining of diminution of vision since past 2 years. And on serial topography, we noted steepening, and a diagnosis of post-LASIK ectasia was made. And RGPs were unstable in this case, and with scleral contact lens trial, the vision improved to 66 in the right eye and 69 in the left eye. Another unusual case in which a 45-year-old male, he had a history of RK in both the eyes in 1994, and he'd been complaining of diminution of vision in the left eye since past 8 years. On keratometry, flattening was noted, and a diagnosis of progressive hyperopic shift was made. And on scleral contact lens trial, the vision improved to 66 in this patient. Coming to an unusual case of unilateral Tedian's marginal degeneration with 360-degree involvement, the vision on acceptance was 660, and with scleral contact lens trial, it improved drastically to 66. For cases for improving the quality of life for the patient, an 8-year-old male presented with Stevens-Johnson syndrome, and he had severe dry eyes on presentation. He was unable to open his eyes, and the patient improved drastically with scleral contact lens trial. A case of 11-year-old female who developed corneal ulcer after using traditional medications in both the eyes, and glue with BCL was done in the right eye and Tenon's patch in the left eye, and the patient presented with severe dry eye, and the patient improved symptomatically after scleral contact lens use. So discussing the pros and cons of scleral contact lenses. It provides a regular surface of fluid which helps with the astigmatism, and this fluid reservoir helps to protect the ocular surface, and it can be used in various peripheral corneal ectatic disorders. However, in case of scleral contact lenses, there is a learning curve associated, and even though the life of scleral contact lenses is longer, these are fragile and the patient needs to take care of their hygiene, and they are comparatively a little expensive. For our setup, which is a government tertiary care setup, it is very important to counsel the patients, because when it comes to the patients, they look at the price factor and they do not focus on the better visual outcome associated. Thank you.
Thank you. That was a very good presentation. I just wanted to know that patient with severe dry eye.
Yes, ma'am.
How did he tolerate the contact lenses? Because they are quite big.
Yes,
the contact lenses are pretty big. He already has severe dry eye. Did he agree there was some improvement?
Yes, ma'am.
Not very much improvement in him.
Ma'am, the patient improved drastically because of all the keratinization of the lids. The patient had a lot of foreign body sensation, so we have prescribed him scleral contact lenses, and we are giving eye lubricants along with it, and the patient is pretty happy with the result because it's a young patient.
I agree. Okay. Anyway, thank you.
You use the same brand scleral contact lenses in every case?
Yes, sir. Yes, sir.
Okay, sir.
And you mentioned about the cost factor. It is a significant factor.
Yes, ma'am. It is a significant
because
factor.
I have some patients who have sent for scleral contact lenses to someone else, and they at first refused to
yes, ma'am.
take them because of the cost factor.
Yes, ma'am.
Because they said, and then that girl, she was around 21, 22, recently married, she lost one. So you can imagine
Yes, ma'am.
the financial burden.
Ma'am, in our setup, roughly we are giving contact lens trial for roughly 25 patients a month, but only one patient is buying because of the cost factor. So
Correct.
in this case series, we've included only those who have bought it and who've been using
have
it for
been
6
using it.
months.
Correct. Thank you.
Thank you, ma'am.
Thank you, audience, for patiently listening. And I would request all the judges to be here for a group photograph.
Thank you. And also the participants.
Also the participants. First the judges, then the participants. First, let's have one of the judges only